Yes, sir, she's on.
Can I request Mala to go first? I'll
Sir,
be back in 20 minutes.
Yeah, we can do that because actually Dr. Mala's is a recorded talk. She's in America.
Go ahead.
yeah,
It's fine.
madam.
Dr. Sadhna Gupta, madam.
I welcome you all for this ICOG Guru Mantra. May I request the chairpersons of first session, Dr. Mandakini Megh, Dr. Sheila Mane, and Dr. Sadhna Gupta, who are all closely associated with ICOG. Dr. Mandakini Megh is the past ICOG chair. Dr. Sheila Mane is the incoming ICOG chairperson, and Dr. Sadhna Gupta, who is the ICOG chairperson elect. So can I request the chairpersons to introduce Dr. Mala Arora and to
She was also supposed to join if she's there. Dr. Lakshmi, who's the past chairperson.
yeah, she's not there. She told me she cannot come.
She's not there. Okay, no problem. Then maybe Dr. May can
Yeah.
introduce Dr. Mala and then we can have her talk.
Yeah.
So can you so it's a great privilege for me to introduce Dr. Mala. And when I was the ICOG chair, she was coming up with many publications, and we had very close association with Dr. Mala. She was the past chairperson of ICOG 2017-18, Vice President Foxy 2011. She was the editor of the recurrent pregnancy laws, and also many ICOG annual books also she has written. She is the founder of the Indian RPL Foundation and vice chairperson of the Society for the RPL. Chief editor for many books like Recurrent Pregnancy Laws, World Clinics, Yearbook, Evidence-Based Medicine, Endometriosis, associate editor of the International Journal of Infertility and Fetal Medicine, and also the British Journal of OBGYN. And above all, a very, very nice, decent human being, a very warm and kind, and I have a very special relationship with Mala. So I think with these words, we should start the lecture of Dr. Mala. You can start the lecture of Dr. Mala. It is recorded, no?
Yeah. Gauri, please share the recording.
Okay. Good evening, everybody, and welcome to this ICOG Guru Mantra web series. I must congratulate the current office bearers of ICOG, Dr. Parag Biniwale and Dr. Sarita Bhalerao, and the convener, Dr. Gita Balsarkar, for this wonderful initiative. And I'm honored to be a speaker on the first program. With the blessings of our Guru, we have currently launched the 4th edition of the textbook on recurrent pregnancy loss. And this was launched at the World Congress on RPL in Singapore in January, as well as at Mumbai AICOG. There are quite a few new developments, and I have also great pleasure in announcing that we are in the process of launching the International Journal of Recurrent Pregnancy Loss. And I urge all those who have original research on this subject to kindly publish it in this prestigious journal. So coming to the topic today, I will clarify what are the new developments, but I have to start with the fact that we still do not have an international consensus on the definition. The RCOG continues to define it as 3 or more consecutive pregnancy losses, but both the ESHRE and ASRM define it as 2 or more consecutive losses. It is important for research that we conform to a single definition so that we can make progress in treatment protocols. And another common confusion is the terminology. We have changed from recurrent abortion to recurrent miscarriage because abortion is now only denoting self-induced procedures to terminate a pregnancy, whereas miscarriage is a spontaneous loss of pregnancy. Whereas miscarriage denotes all pregnancy losses before 12 weeks of gestation, recurrent pregnancy loss includes all losses up to the period of viability, which is now considered 24 weeks. It is truly multifactorial in etiology, and I will take you through the various causes like infection, autoimmunity, paternal factors, maternal age, genetic factors, anatomical and hormonal factors. But first, some tips you need to give your patients on lifestyle factors. This graph denotes how maternal age affects the incidence of RPL, and hence it becomes the duty of us as obstetricians to sensitively inform women that pregnancy loss rates are lowest between the ages of 20 and 35 years. Not only maternal age, but paternal age above 40 years and 45 years is also well. And so now we know that lifestyle factors, both in the mother and the father, will induce changes in the products of conception, which will make it more common to have miscarriages. So couples should also be informed that both maternal and paternal obesity is associated with RPL, and so a fitness for fertility should be advocated for both partners. Avoidance of harmful substances like alcohol, smoking, drugs, and the biggest threat I feel in today's day and age is the contamination of our food and grain with pesticides. So it is important that we take care of the fruit we consume and the food we consume. A big question asked by most couples when they come to your clinic is, can stress cause miscarriage? We have a lot of research that points to the fact that stress not only alters the endocrine axis and raises prolactin levels, but it also alters the immune T cell function. And so maternal immune adaptation to pregnancy is impaired. Whereas current evidence suggests that stress is associated with RPL, but it is still not proven to be a direct cause of RPL. Nevertheless, I think the biggest service you can do to all your RPL patients is to dispense tons of tender loving care and empathy so that their stress is minimalized, although it is never possible to reduce stress levels in patients with RPL. Coming to the first most important cause that you will encounter, and that is a genetic cause of miscarriage. We knew that fetal aneuploidies are associated with miscarriages, and parents that carry balanced translocations can also have miscarriages. But now we know that single gene defects, sperm DNA fragmentation, and epigenetic factors are also implicated. Fetal aneuploidy has been studied the best, and it is associated with maternal age. So it is important that we sensitize women to treat reproduction seriously at a younger age. But of the multitude of tests that we can do on the products of conception, like FISH, QF, PCR, CGH microarray, and next generation sequencing, I wish to bring to your notice that we no longer do karyotyping because of the high maternal cell contamination. The preferred mode of testing is CGH microarray, which can pick up large genetic defects and aneuploidies. But in patients that may be having a single gene defect, we have to resort to next generation sequencing, which is slightly more expensive, but again, a highly accurate method of testing. So please remember that instead of karyotyping, we do a CGH microarray. Should we test all couples for parental balance translocation? Well, the ESHRE guidelines state that parental karyotyping is not routinely recommended unless the products of conception show a genetic cause of miscarriage, or if there are no products of conception available for testing, as in recurrent biochemical pregnancy losses. In those couples where we do identify a balanced translocation, it is so important to send them for genetic counseling because these couples still have around 80% chance of having a normal pregnancy with their own gametes. So it is important that we let them try with appropriate genetic counseling. Donor gametes are used as a last option only when couples have recurrent aneuploid pregnancy losses. And then it is prudent to resort to IVF with PGT-A. And now in this era of artificial intelligence, we have the AI tools that will tell us which is the best embryo to transfer so that we reduce the time to pregnancy. Sperm DNA fragmentation has recently been included by the ESHRE guidelines as a test important in male partners of women having RPL. And those that have more than 30% DNA fragmentation index, the male partner is treated with a variety of antioxidants. We use 2 or 3 of these antioxidants in a combination, not all of them. And these include vitamin C, D, and E, coenzyme Q10, L-carnitine, and lycopene, along with zinc. Minimum duration of treatment is 90 days, but could be longer. And retesting to see if DNA fragmentation is normal is also a valid option. When it comes to genital tract infections, we earlier thought that only very evident infections like hydrosalpinx would lead to a miscarriage or implantation failure. But now we know that subclinical endometritis and various other things like bacterial vaginosis, cervicitis, latent genital tuberculosis can all lead to miscarriages. The endometritis changes the uterine microbiome, and multitude of studies show that if the uterine microbiome is not lactobacilli dominant, there can be increased miscarriages. Unfortunately, chronic endometritis is asymptomatic, and it can only be picked up with a vigilant transvaginal scan where we see that the endometrium quality is not trilaminar. It could be echogenic or heterogeneous. Sometimes you may see fluid in the endometrial cavity with small polyps, and the diagnostic test is hysteroscopy and endometrial biopsy. These are small polyps that can denote endometrial chronic endometritis, and these are the pictures on hysteroscopy where you will see micropolyps. What is the treatment? If we are doing an untargeted treatment, then doxycycline is the treatment, is the antibiotic of choice, 100 milligram twice a day for 10 days. However, if by doing QF-PCR, we identify that the organisms are gram-negative or gram-positive, and then we can choose the antibiotics accordingly, like metronidazole with ciprofloxacin for gram-negative bacteria, and amoxicillin and clavulanic acid for gram-positive bacteria. Alternatives are azithromycin and metronidazole. However, treatment can be very successfully supplemented with probiotics. And the probiotics that work for the genital tract are Lactobacilli crispatus, reuteri, rhamnosus, inceni, in a large dose of more than 10 billion colony-forming units. These eradicate the pathogenic bacteria from the surface of the endometrium and facilitate implantation. There is an international scientific association on pre and probiotics that is currently trying to regulate the formulations that are available of both pre and probiotics in the market. And they have also defined live biotherapeutic agents like lactin-5, which is currently being used in recurrent UTI or recurrent candidiasis. Coming to autoimmune disorders, APLA syndrome has currently undergone a revised classification, and this is called the ACR-EULAR classification, which essentially means the American College of Rheumatology and the European Union of Rheumatologists. And they have now widened the definition of APLA to include not just obstetric APS, but vascular APS, which mainly presents with thrombosis, non-criteria APS, which presents with very low titers of antiphospholipid antibodies or a single antibody positive test. And then obstetric morbidity APS, where there is an obstetric history, but the tests are not showing positivity. This is where we were struggling earlier because a lot of our patients that underwent miscarriages were non-conforming to the criteria of diagnosis. We know the treatment is heparin, and heparin has a very powerful complement inhibiting action, and that is why it is so successful in the treatment of APLA syndrome. It is combined with aspirin, but in refractory APLA, we now have an excellent drug called hydroxychloroquine, which is a very safe adjuvant treatment during pregnancy. It prevents thrombotic episodes in autoimmune diseases, and the dose is 400 milligram per day, which is 200 milligram twice a day, combined with low molecular weight heparin and aspirin. In still more refractory cases, we can resort to intravenous immunoglobulin or IVIG, and this is started as soon as the pregnancy test is positive and repeated every 3 weeks. Apart from APLA syndrome, all other autoimmune causes can disturb the maternal adaptation to pregnancy by increasing the natural killer cell count in the endometrium. And hence, when you see a woman clinically with either vitiligo, alopecia areata, or any other form of autoimmune diseases, we know that her chances of miscarriage are increased. We also now have recommendations that doing the anti-nuclear antibody testing can be important in patients with unexplained RPL, and a titer of more than 1 in 160 persistently positive puts her in the category of an autoimmune cause of RPL. A vegan diet benefits many autoimmune disorders and has a lot to be advocated. We know that the gut in autoimmunity is associated with like a leaky gut, which is presenting undigested protein molecules from the intestine to the autoimmune cells, and that is why the autoimmunity is flared up. We have a lot of drugs that we can use, but before that, we can use probiotics and healing nutraceutical chemicals like L-glutamine and acetyl-glucosamine. Vitamin D is also an important part of autoimmunity, and it is important we optimize everybody's vitamin D levels by either oral or parenteral administration of vitamin D. IVIG has definitely been used in autoimmune RPL, but there are recent papers to say that even in unexplained RPL, where you're not finding an autoimmune cause, a high dose of IVIG started in early pregnancy may give beneficial results. And the 2022 ESHRE guideline group recommends high-dose IVIG in women with 4 or more unexplained recurrent pregnancy loss. Can intralipid be substituted for IVIG? Well, intralipid is a weaker agent than IVIG. However, it is cost-effective and has no adverse reactions and is extensively used empirically. However, if the natural killer cell activity is high, the IVIG gives much better results. And even in other autoimmune disorders, apart from Apla's syndrome, we can use hydroxychloroquine in combination with other drugs. Whether steroids are used in autoimmunity, again, there is a small subset of RPL patients which have very high natural killer cell counts where we can be justified in using steroids, but it is always done in conjunction with a rheumatologist. There are other drugs which are TNF alpha blockers, which are now being tried successfully in patients that have high TNF alpha levels, and these are adalimumab or other TNF alpha blockers. And there are a few studies which show that their use is safe for the fetus in pregnancy. Coming to anatomical causes, and I don't need to spend much time here because you have heard an excellent talk by Dr. Nozer Sherrier on the subject, and these disorders need to be corrected surgically. Most important is the septate uterus or removal of submucous myomas. Coming to the hormonal causes, the most important message I wish to give you here is that when you test thyroid function test, you must combine it with antithyroid antibodies because it is high antithyroid antibodies that are associated with RPL. There is this thyroid dilemma where we have different guidelines whether we should treat euthyroid patients who are antibody positive or leave them alone. We know that if there is overt hypothyroidism, we need to treat them. If there is subclinical hypothyroidism, we still treat them. But what do we do with patients that have totally euthyroid levels but are antibody positive? There are some studies to say that you can treat them with levothyroxine if their TSH is more than 2.5. But if the TSH is less than 2.5, you just keep them on a very close follow-up. So these are the recommendations by ESHRE that TPO antibody screening should be an integral part of thyroid testing. And the recent systematic review and meta-analysis supports the use of levothyroxine to improve pregnancy outcome. We have now pretty much covered all the causes that we started off with in our initial presentation. And I want to now take you through the most difficult part, and that is unexplained RPL. There are unequivocal guidelines that all women should receive folic acid 5 milligram daily, and they should have optimum vitamin D levels pre-pregnancy. They should be counseled for their fitness and avoidance of all lifestyle factors. But the controversy on whether we should give them progesterone or not is still not very well settled. The ESHRE Guidelines 2023 say that there is insufficient evidence to recommend progesterone for women with RPL and luteal phase insufficiency, but The ACOG guidelines state that progesterone therapy will benefit women who have experienced at least 3 prior pregnancy losses. And the recent FIGO guidelines in 2023 has emphasized that synthetic progesterone, like dydrogesterone, is more effective and there may be no role of natural micronized progesterone in RPL. Hence, most of us are still treating our patients on unexplained RPL with folic acid, vitamin D, and progesterones. And with this, I come to the last part of my talk, and that is your take-home message. It is important that all patients presenting with 2 or more miscarriages should have a complete panel of testing for RPL. This includes the genetic causes by CGH microarray of the products of conception, APLA screening with the 3 tests, the antibody testing, the lupus anticoagulant, and the anti-beta-2 glycoprotein 1, a thorough evaluation of the uterine cavity with either a 3D ultrasound or a sonohysterogram, endometrial evaluation, if the need be, an endometrial biopsy and the study of plasma cell count in the endometrial biopsy to see if there is chronic endometritis, thyroid function test with antithyroid antibodies, both the thyroid microsomal and the TPO, thyroid peroxidase antibodies, and a paternal evaluation with not just a semen culture, but with sperm DNA fragmentation and counseling for lifestyle factors, and lastly, testing for autoimmunity by antinuclear factor. Once you have your patient completely worked up, it will be easy for you to do a targeted correction. And the good news is that in the group of RPL, the advanced genetic testing and the inclusion of antibody testing and testing for chronic endometritis is slowly reducing the percentage of women we now class as unexplained RPL. And soon, I hope, we will be having an answer for every couple that comes to your clinic with RPL, and we should be able to implement evidence-based treatment for them. Thank you very much, and I will leave you with this last slide.
So thank you very much, Doctor. Sadhna, Sadhna, yeah.
Brilliant talk, none other by Dr. Mala Arora, who is known for her great extensive publication on the subject. And a lot of issues are there, right from genetic and immunological to simple nutritional deficiency. And few things actually, when we have too much of information, we have too much new insights like genetics and the probiotics and the gut microbiota. The important thing for clinician is that individualize the thing, and few things when you say which investigation to do in these patients, you have to review what has been the previous obstetrical loss. So review of the previous ultrasound, it was blighted ovum, or it was only yolk sac, or it was after demonstration of cardiac activity. That gives you a good clue where you should focus most. It is the anatomical cause, which is like a cavity issues, or there has been the genetic and the immunological loss, which actually contribute to around 90% of early pregnancy loss. So individualization is very important, and especially for India, like if you give around 40-50,000 to the patient who is having pregnancy loss, right from a low middle or a former class, it becomes very, very exhaustive, very difficult from them. And despite that, we always have a lot of unexplained pregnancy loss because we are having more and more insight. So with the brilliant talk, with the brilliant all-inclusive summary on the recurrent pregnancy loss, the important question is that sharpness and alertness of clinician, that what is the specific cause in this particular couple and where we should focus most and how we should treat that. And environmental pollution, this is the thing when the most rich country, US, who are like having the most exhaustive use of the environment. This is very important, that the high temperature, what we are having a heat in the February and March, the high environment and all environmental pollution, which Dr. Malarura has also said, in our home, in our food, that is the thing which is actually has to be taken by the professional bodies. And I think we at ICOG and FOXY will also continue to do this work for the awareness, as well as whatever we can do in our capacity. So thank you very much, Dr. Malarura, for the brilliant deliberation. And with this, I hand over to my co-chairperson.
Thank you, Dr. Sadhana Gupta, for that conclusion. May I request Dr. Sheila Mane to introduce Dr. Nozer Sheriar? Dr. Sheila? Madam, Dr. Sheila Mane, can you introduce Dr. Nozer Sheriar?
Yeah, can you hear me now?
Yes, madam.
Yeah, I was muted, that's why. Okay. Can I have the CV, please? Can
Yes,
I have? Yeah, thank you. Yeah. So good afternoon, everybody. It is my proud privilege to introduce none other than Dr. Nozer Sheriar. And all of us are familiar with him. He is a past Secretary General and past MTP Chair of FOXY, past President of MOGS, and he's at Breach Candy, Hinduja Healthcare and Holy Family Hospitals.
Thank you, Sheila.
Fellow honoris causa RCOG. No, sir, I always take this an opportunity for people to know, otherwise many people will not know many things about our own people. Okay. So, fellow honoris causa RCOG, AOFOG Young Gynecologist Award, Chair Scientific Program Committee of, I think, 22nd FIGO Congress, member of Technical Advisory Group WHO, and SCA Region Co-Chair Medical Advisory Panel, FPA India Director, and Guttmacher Institute and Center Catalyzing Change. So he has edited many books, published many papers, and written many chapters. He's been awarded with Dr. Hansotia Best Committee and Dr. Duru Best Publication Award. And from MOGS also, there are many awards to his credit. That is Bhatia Young Scientist and Ganatra Community Service, and Dr. Desai Excellent Mr. and Mrs. Pandit Award. So my pleasure to introduce you, Dr. Nozer, and over to you for this innovative series, Guru Mantra.
Thank you so much. Thank you, Sheila. Thank you, ICOG. The office bearers of ICOG, I think this is a fantastic program that you're conducting, and it's really an honor to be a part of this program. I'll start by sharing my screen. I hope you can see the slideshow.
Yes, we can. Yes.
So this is a philosopher I greatly admire, and this is one of my favorite quotations where he said, "The true voyage of discovery is not in seeking new lands, but in seeing with new eyes." And for me, hysteroscopic surgery really signifies that quotation. Today, I speak to you about the uterine factor, primarily in reproductive loss. And let's face it, today, hysteroscopy has become the gold standard for this particular condition. Now, we all have a lot of opinions, particularly I heard Mala's talk, and I attended a fantastic master class in Delhi that Dr. Amit Patki and Isar had organized on just this topic. Everyone has a pet theory and a treatment when it comes to reproductive pregnancy loss. So it said that facts are stubborn things. Whatever may be our wishes, our inclinations, or the dictates of our passions, they cannot alter the state of facts and evidence. So how about when it comes to this particular problem of recurrent pregnancy loss, we see where evidence now exists and create evidence where it doesn't. So first of all, looking at when a hysteroscopy is done for ART, this was a study where a very large kind of a combination of studies, 15 studies, 5,000 women. Either there was no hysteroscopy, there was hysteroscopy before the first ART and hysteroscopy after a failed ART. And interestingly, if hysteroscopy was done before the first ART, your pregnancy rate increased because you picked up problems which you otherwise would not have. Your implantation failures were less, and whenever an operative hysteroscopy is done, your RR went up by a dramatic over 2. When you looked at the live birth rates, again, there was a higher chance but interestingly, when hysteroscopy was done after a failed ART cycle, you had the best successes when it came to live births, and you didn't seem to have. So maybe what we are seeing here now is you don't need a routine hysteroscopy. You definitely need to address the uterine factor. But I shall tell you today that I personally believe that can be done by imaging. Now, when you look at the investigations, recommended investigations for anatomical problems, okay, the prevalence of uterine malformations is definitely higher in RPL, almost 2.5 times higher. It's almost the same for 2 and 3 losses, which basically leads me to believe that if you have 2 or more losses, the investigations must happen. You don't have to wait for 3 losses that a number of international guidelines would tell you. And I would go to the extent of saying some of these things can be looked at after the first loss because a 3D ultrasound is non-invasive, it is simple, and it is more widely available now. Now, when this study was done of women with RPL, they found that about 13% had acquired and about 7% had congenital defects. About 20% of women with recurrent pregnancy loss had a uterine factor. And if you look at the ESHRE guidelines, which came out in 2023, a very strong recommendation that you should assess the uterine anatomy in RPL, and a conditional recommendation which says that 3D ultrasound should be the preferred technique, and that sonohysterogram is more accurate than an HSG. So, I mean, these are just some of the things you pick up now with a 3D ultrasound. These are all patients in my practice, whether it be a submucous fibroid, a polyp, an arcuate uterus, a septate uterus, a T-shaped uterus. These can all be picked up beautifully by ultrasound. So let's go over a few conditions, and I'll start off with intrauterine adhesions, where Ogilvy has said advance means progress to something better, not progress to something new. Once upon a time, you treated intrauterine adhesions by a blind curettage, and it worked in some patients. But for a majority, you needed hysteroscopy. And we have been now doing this for a long time. So the first papers came in the 70s and 80s, and there was this fabulous paper by Val and Ciara. 88 was when I was getting passionately involved with hysteroscopy. And those were the most productive years, those 2 or 3 years. Pre-treatment viable pregnancy, 15%. Post-treatment viable pregnancy, 97%. Now, when you talk about adhesions, there are so many different, I won't get into the nitty-gritty. This is the ESGE classification. It goes 1, 2, 3, 4, and 5, and it describes the extent of scarring, fibrosis, and invasion. And as you move higher up, the chances of having major menstrual disturbances are greater. And then there is the simpler AFS classification, which kind of grades the extent of cavity, type of adhesions, and menstrual pattern, and then come up with a staging, a mild, moderate, and severe staging. This is something we use routinely and can be easily done. I must confess, I still do HSGs and lots of them. I, at one point in time, thought that that surgery had made HSGs obsolete. On the left-hand side, you're seeing a columnar intrauterine adhesion. It was cut. The second picture is below it, and that child The patient that come to me from Goa is now probably in the late 20s. On the right-hand side, you've got almost an AFS stage 3 adhesion. You can't see the cavity at all. But when you break through the adhesions, the cavity opened up, the tubes opened up, and she went ahead and had a pregnancy. Now, conception rate, if you look at these procedures, is something that, sorry. If you look at the incidence of menstrual patterns on conception rate with adhesions, obviously with amenorrhea, it's less. With normal menstruation, it's greater. And if there is a recurrence after your hysteroscopy, it's less. With the normal cavity, it's better. And there was this study by Campas who showed that there was a large series of hysteroscopic adhesiolysis. Intrauterine pregnancies happened in 52% after adhesiolysis, a little lower with the type 4 and 5 adhesions, and similar rates with one or more procedures. So now, let me just walk you through a case where we had severe intrauterine adhesion, so severe, this patient had 2 miscarriages. When this was looked at, one doctor said, "You'll never have a pregnancy, go for surrogacy." Another doctor promptly started her anti-cox therapy. When she came to us, I said, "You've had 2 miscarriages. You owe it to yourself to have that cavity assessed endoscopically." And you can see how initially with the scope and later on with the resectoscope, not the scissor, the resectoscope, and I'll explain why, we managed to open out. Normally for adhesions, yes, most people would prefer a scissor, but when it comes to extensive adhesions like this, the control that I would get with the Collins knife, you see how we are opening up that cornu, which was closed. We are clearing up the right lateral wall. We are reunifying that cornu, and we went ahead to create an almost completely normal cavity. And the same patient since then went ahead and had 2 normal pregnancies. Well, in one of the pregnancies, she had hepatitis E. So I can't say normal, but pretty normal pregnancies. And someone would be told that you'll never conceive, you have only the choice of surrogacy. If adhesions are there and they can be corrected, you can have fantastic results. So this is the evidence. Hysteroscopic adhesiolysis in 126 of the people trying to conceive, 70% pregnancy, 60% live birth rate, miscarriage in 13%. And it's shown that hysteroscopic surgery led to live birth in a majority. This is a little bit of our personal data from actually from quite some time ago. And I can tell you that in our country, there is something unique compared to the West. A lot of our intrauterine adhesions happen because of tuberculosis. So a lot of them will be primary amenorrheas. But when you do have a secondary amenorrhea, you can see 74%. You had an improved menstrual pattern in almost 87%, but in a secondary intrauterine adhesions, we had viable pregnancies in over 80%. And if it was primary, it was 55%. So now I think this is the ESHRE guideline again. Intrauterine adhesions are frequently detected, though sometimes it's difficult to know whether they are the cause or the effect of a previous DNC. Secondly, there's insufficient evidence on the benefit of adhesiolysis, but I can tell you on a very practical note that if you have adhesions distorting the cavity, disturbing menstrual function, for God's sake, correct them. And then, of course, there have to be post-hysteroscopic procedures to prevent recurrence. You could use an intrauterine balloon or something like that. Going ahead, this is a patient in whom we had, and Mala mentioned endometritis. And this is just one slide here to tell you that you have unexplained recurrent miscarriage, and a certain number of patients will have chronic endometritis where there'll be micropolyps. And you're doing an endometrial biopsy for immunohistochemistry and culture would help. And look at this, chronic endometritis related hysteroscopic signs in RPL, 30% endometrial cultures, and you had in almost 38% they were positive, and the commonest pathogens were mycoplasma. A standard protocol for evaluating the uterine cavity prior to infertility treatment, normal cavities in 144 with subsequent miscarriage, incidence of intrauterine adhesions, and there was a significant association when you did the procedure where you increased size. They said that mechanical suction dilatation and DNC were a risk factor. And this is my pet belief. MVA was not a risk factor. So in my practice, no more curettes. I haven't used them for the last 25 years. Almost never use a metal cannula. Please use an MVA whenever possible. This is just to show you how MVA works. You can see this cavity. This is a gynac DNC. This is just a by the way. I just did a suction evacuation, got this lining out, and you won't believe how well MVA will clear a cavity. You don't need a curette. Coming to myomectomies. Polyps, yes, are significant, and interestingly, hysteroscopic polypectomy improved clinical pregnancy rates versus controls. This is when you're dealing with infertility. You may use a scissor. You may just push with a loop with a very slight touch because there is usually a fleeting vessel, and before it'll come off extremely easily. Hysteroscopic removal of polyps prior to IUI. This is a Cochrane review, and they said that without polyp removal, the pregnancy rate was 28%, but after a polypectomy, the pregnancy rate was 63%. Myomas can be classified by many different ways. There's the FIGO classification. You can see there. I'm not going to go into it. I'm only interested in 0, 1, and 2. And there's the ESGA classification, which is the type 0, 1, and 2, depending upon how much of the fibroid is in the cavity. Fibroids do make a difference. This is a study which showed that when you had subserous fibroids, almost no effect. Intramural fibroids had an effect. Submucous, significant effect in terms of both pregnancy rates and implantation rates when you were dealing with infertility. Now, this is a submucous fibroid, an ESGE type 0 fibroid. Now, this fibroid can cause significant menstrual disturbance and pain. This fibroid is resected out. However tempting it is to cut the pedicle, please don't do that. You will not be able to remove the fibroid. After that, it will become a floater. It's only when you've gone through most of the fibroid this way. It's very simple, this procedure. It's a pure cutting current. And at the end of this, you just go and cut the pedicle and you clear the whole cavity. So this is when you're dealing with a submucous fibroid of coming to a fibroid which is partly submucous. In this case, 3 are submucous fibroids. 3 of them are intramural fibroids. You always do the submucous first. You always do the posterior ones first because all the chippings will fall there, and the same principle is followed. When you finish with the submucous fibroids, you turn your attention to the intramural. Now here we are doing the intramural. And once you've kind of opened out the capsule, the fibroid will start pushing into the cavity. And the trick is to teach yourself how to identify the capsule, and then you can get the largest fibroids out hysteroscopically. Now, this was a systematic review of many studies. Submucous fibroids were associated with lower pregnancy rates. Intramural fibroids had reduced pregnancy rates, and pregnancy rates following myomectomy improved by almost 2 times. This is the evidence-based guidelines of the RCOG. And this study showed that at 12 months, pregnancy rates were doubled after the removal of a submucous fibroid. Our experience, a majority of fibroids were causing menstrual disturbances. But when you had infertility, removing a fibroid gave you viable pregnancies in 76%. Now, what's the Eschri recommendation? Now, this is a little tricky, and here I will beg to differ with this recommendation. Eschri said that observational studies had pregnancy, live birth, and miscarriage rates after myomectomy similar to infertility without fibroids. AAGL recommends that selective submucous myomectomy should be done. But Eschere says that there is insufficient evidence for removal of submucous fibroids or polyps in RPL, and that removal of intramural fibroids is not recommended. The second, I agree with. The first, I do not. Coming to adenomyosis. Now, this I'm going to very briefly touch upon this because most of us are now encountering adenomyosis like never before. The principle of doing something for the adenomyosis comes from TCRE, where if you resect the lining and you get the crypts out, you get benefit from her symptoms. Now, when we are dealing with patients who need fertility, and that's become the challenge now. And you know that many of us are dealing with pregnancies with adenomyosis now. It's a completely different kind of a ball game. So now the theory is, or by theory, we're actually doing it, targeted excision of adenomyosis. If an ultrasound shows you a large crypt or an adenomyoma sitting close to the endometrial cavity, and if you have ruled out everything else, or if she is very symptomatic, you can treat that without harming the reproductive function of the uterus. So you can see here, we are doing a hysteroscopy here. You've got the polyps in front, you've got the slight endometrial hyperplasia behind, and that's how you get the polyps. But in this particular case, we decided that there were crypts close to the cavity. We knew where the crypts are because you do your, look at that little dome of tissue there, and you can see that there. That's an adenomyotic crypt which we've de-roofed and then systematically go in and excise the walls of the crypt till you reach the base of the crypt. And doing that, you've solved this one particular problem for this cavity. You have to be very tight in your movements. Of course, I do TCREs routinely for these patients, and I'll be more aggressive. But if I need fertility, I'm just going to go and do that area and nothing else. This was a study of adenomyosis in pregnancy, and this I won't get into now, but just to tell you that with pregnancy, it has been found that your chances of miscarriage before 12 weeks, after 12 weeks, and preterm delivery are really high. I think it's time for us to study this better. All of us are now dealing with more and more cases of adenomyosis and pregnancy. And of course, when an adenomyomectomy is done for these patients, because sometimes it might be a very localized kind of disease, it could be done hysteroscopically, laparoscopically, or open. You can find here that when you have these patients after an adenomyomectomy, you did have successes and fewer recurrent miscarriages. Now, finally, I'm going to touch upon the two things that fascinated me about hysteroscopy. The first was a septate uterus. Arthur C. Clarke has said, any sufficiently advanced technology is indistinguishable from magic. That's the AFS classification. We are going to talk about on the classification type 5 and type 7. Type 5, the septate and the subseptate. The type 7, the T-shaped or the drug-related. And then you also have the congenital uterine anomalies classification, the CONUT A classification, where you can see that the class U2 uterus is the subseptate uterus, and the class U1 uterus is the dysmorphic uterus. The first papers were March in Israel. That made me fall in love with hysteroscopy. They told us that if a septum was cut, a pre-treatment pregnancy rate loss of 95% went to a post-treatment viable pregnancy of 85%. This is a complete septum. Once upon a time, I would have done it in 2 or 3 stages. Cut the vaginal septum, then cut the uterine septum, then cut the cervical septum, and then the uterine septum. Not anymore. Now we know what we are dealing with. The first thing I do is I cut the vaginal septum very quickly. Now you have converted to a kind of a septate uterus. And after you've done that, you take a Mayo scissor and just cut the lowest part of that particular septum. You've now converted it to a subseptate uterus. Now you can see that here, and then you can put your telescope in, see the two sides of the subseptate uterus now, which used to be a septate uterus, and then you can kind of reunifying it by septal incision. This is an incision. This is not an excision, which is why terms like septectomy don't make sense to me. I prefer septal incision or whatever works for you. You can see how we are cutting upwards. You're seeing here the cavity is opening out, this almost a pure cut current. And the beauty is that once you do this, this cavity will be completely normal in no time. We initially did second look procedures. Very soon we stopped because there didn't seem to be any value for them. And this particular study showed that the uterine septum is more common in women who have had recurrent pregnancy loss or preterm birth. Again, they said metroplasty not shown to increase pregnancy rates for infertility, but I beg to disagree, because we know that sometimes when all else is ruled out, this could be the case. And in 80% of pregnancies with subseptate uterus, you have a miscarriage, and this can be helped. Again, this is another study, an observation study, which showed when they pooled the data that your odds ratio of having when you have a complete septum miscarriage is extremely high with a complete septum and a partial septum. And preterm birth also decreased significantly after having cut the septum. Our patients, this was 221 cases. There was a single loss in 40%, two losses in 30%. And all I can say is a pre-treatment viable pregnancy rate went up from 14% to 88%, telling you its value. Another meta-analysis, this is again Estray's recommendations. Single small RCT showed no benefit to reduce losses. Unfortunately, nobody has the who will do an RCT now for a septum, because it's kind of given that you correct it. But one very strong recommendation is there, and I want to reiterate it. There is no place for correcting a bicornuate uterus. And it breaks my heart when I sometimes see people demonstrating this in conferences and doing laparoscopies and laparotomies for them. That uterus does not need a correction. It will function very well on its own. And finally, the T-shaped uterus. I got involved with this in the early 1990s. Once we saw the first paper, they were coming in, and you suddenly saw that a T-shaped uterus had a higher abortion rate, had the lowest term delivery rate. There was a first report in 1989 of correction of a T-shaped uterus by an open surgery. And very soon we were doing it hysteroscopically. The first paper came in 93. We cut our own septum, first septum in 1993. And you can see the results since then. The uterus is not T-shaped, the cavity is. And once you start off with this procedure, you go in hysteroscopically. Here you can see I'm making a dot to decide how low I can come down. And then I go up and I make these lateral incisions. And that way the cavity opens up. You're cutting a constriction band. Then I go up and do the fundus, because the fundus is very often like an arcuate uterus. And once this is done, we hold the walls apart by a balloon. And then later on, once it's healed with estrogen, progesterone treatment, she can start planning her pregnancy. Some before and after pictures above and below, and you can see how the cavity has improved. And again, in our series, a pre-treatment viable pregnancy rate of just 18% went to 76% post-treatment. So of these two, I'd like to compare the two. And that when I compare the two, I want to show you that doing a septum increased your outcomes from 3% to 71%. This is Sukur's paper. And this is not a small number of cases, 96 and 76. Treating a T-shaped uterus improved success from 4% to 62%. So I'd like to finally finish this talk. And again, I want to thank all my friends at the ICOG who've been in touch with me, Geeta and Sarita, and everyone at the ICOG office. I'm so happy that Dr. Meg is here, Dr. Sadhna Gupta is here. And one of my favorite quotes of one of my favorite authors, Arthur C. Clarke, is, "The only way of discovering the limits of the possible is to venture a little way past them into the impossible." I think Mala did that with her presentation. There was so much new material out there of things we never thought about 10 years ago. And sometimes when my patients tell me that why don't we know the cause? And I said, 10 years ago, we didn't know thrombophilias. 20 years ago, we didn't know APLA. 30 years ago, we didn't even know about things like hyperprolactinemia. So medicine evolves and we've got to keep ourselves abreast. So thank you so much for this invitation. It's been a privilege.
Thank you. Thank you, Dr. Nozer. I think it was a very good presentation. And I must say, watching so many videos, I mean, it was like a reality show where we could see all the conditions. And of course, the skill of the surgeon matters a lot, but it was very clear. Even, I mean, all the conditions like polyp, fibroid, and also the adenomyosis you touched upon. And I think really agree with you that I don't know, suddenly we see there is a rise in adenomyosis. Every other patient you scan, you find focal adenoma. And yeah, pregnancies also with adenomyosis now we are getting. And it is really happening to see. So endometriosis is on the rise, and so the adenomyosis. So a wonderful talk, both of you, Dr. Mala, as well as you. And I think it was a real guru mantra for all of us. So thank you very much. And on behalf of ICOG, Dr. Parag, he's not able to come. I think he's outside the country. So on everybody's behalf, I thank both of you for being with us today to deliver this excellent talk as well as the deliberations. Thank you. And I wish happy Holi to everyone here, and have a nice time today and tomorrow.
Thank you, Sheila.
Thank you, Dr. Sheila Mane. Thank you, Dr. Nozer, Dr. Mandakini Meg, and Dr. Sadhna Gupta. And a big thank you to Dr. Sarita Bhalerao and Dr. Parag Biniwale from ICOG, who gave me this chance to convene this session. Thank you all.
Thank you, Dr. Nozer. That was a wonderful talk. It was really a pleasure listening to you. And thank you, Geeta, for conducting this program. I think this is our first Guru Mantra for the year. And it's been fantastic, that we have you as our first episode. And I invite everybody for this program. We're going to have it month after month.
Thank you.
Thank you.
Thank you.